Good afternoon and welcome to today's edition of Black Hill Trust. We're so happy to be with you and share this time with you. These are some exciting days, and we've got some very interesting things to discuss today that are going to impact our lives going forward for sure. Without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. Happy Sunday. We have a good topic today. We've often been involved in a lot of technologies, and sometimes they are good for us and sometimes they go wrong. Our topic today is the benefits and risks of medical technology that we all have come to depend upon and hope for. Simon, give us the first slides, if you would. So, medical technology, its benefits and risks versus risks. We know these procedures save millions of lives annually, and understanding both the benefits and the risks of these is very important. It's important that you have informed decisions for work using these processes. It can save your life or it can cause you serious problems. Next slide. So, how should we think about these risks versus benefit issues? Absolute benefits include life-saving, morbidity decreasing, relative risks, short versus long-term, patient-specific vulnerability, who's vulnerable, and availability of safer alternatives if there are any. Next slide. So one of the most common things that we are advised about is the technology around diabetes. Next slide. So we know about hemoglobin A1C, which is a measure of your blood glucose over the past 90 days. We know about continuous glucose monitoring, the little things you put on your arm, back of your arm. It tells you what your blood sugar is. Point of care glucose meters, finger sticks. So we know that there's also remote monitoring device that can measure your blood pressure, your respiratory rate, your O2 sat, etc. Next slide. We know also that there are therapeutic technologies such as insulin pumps, closed loop systems, smart insulin pens, and digital coaching apps that all help us. Next slide. Well, the benefits are it improves glycemic control. It reduces hypoglycemia if it's working. There are real-time data that you can use. And there's patient empowerment software that we can also use. Next slide. So risk and limitations. If the device malfunctions, there's a problem. It can give you inaccurate readings. It can give you a sense that you over-rely on technology. And also there's cost and access barriers that happen. Next slide. So there have been recently reported issues with some FDA devices. They have false low or high readings, which can cause hospitalizations and even deaths. Sensor compression errors, Bluetooth connecting loss, and delayed glucose readings. So you have to look out for those and be prepared. Next slide. So also we know about Freestyle Libre and other similar devices that they've had recent things that have killed people or put people in the hospitals. So it's important that you have a way to substitute for those by carrying in your purse, briefcase, or whatever, especially if you're traveling, what you can do if your device is not working right, because there's a failure with adhesives and calibration assumptions, so make sure you have a backup system in those. Next slide. So you want to be prepared, confirm your symptoms using a finger stick, keep backup meters and strips, carry batteries and chargers if you're traveling, and have sick day rules if you get sick. Next slide. So Barbara would take the next slide, please.
Happy to. So, what should we think about when technology fails? Well, first of all, we want to remember that it's the patient that is the center of our attention and not the device. And we want to identify symptoms and, if possible, have capillary glucose readings so that we can have an accurate picture of what's going on and maintain written insulin plans.
Next slide.
Cardiology and structural heart terms. TAVR, transcatheter aortic valve replacement. LAA, left atrial appendage. The left atria is the smaller chamber of the heart on the top. You can think of the heart as a two-story house. The atria on the second floor and the ventricles on the first floor. Watchman, left atrial appendage closure device. Now, Watchman are devices used to prevent clots that form in the legs from breaking off and getting up to the lungs. Next slide, please. Randall, you want me to talk about kidney disease?
You can. A pediatrician, go and talk about it.
All right. Kidney disease and metabolism terms. CKD, chronic kidney disease, or as I write in my patient letters, your kidneys are not working well. ESRD, end-stage renal disease. That means your kidneys are really not working well. EGFR, estimated glomerular filtration rate. That's a measurement of kidney function. And AKI, acute kidney injury. This is referring to measurements that of things in the blood that indicate that the kidneys are not working well, but it's of an recent onset or acute onset,
And it can be
separate and
reversed.
distinct from chronic kidney disease.
Yeah. Are our other co-moderators with us? Is Dr. Hines, Dr. Lawson with us?
Not yet.
Okay. So let's go to the next one. So the diabetic in cardiometabolic terms, such as DM is diabetes mellitus. Type 2 diabetes mellitus is the normal adult onset diabetes we talked about. FDG uptake, that's tissue glucose utilization for PET scanning, imaging. And length of stay is LOS. Next slide. So I'm going to these because we're going to use some of these terms as we go on. So imaging terms, radiation terms. PET, PET, is positive emission tomography. PET/CT, positive emission tomography, computer tomography. So it's a combination of the two. CT is computed tomography, or CT scans. FDG is the fluoroxyglucose, which is a radioactive compound that they give you before you have a PET scan. ALARA means as low as reasonably achievable in radiation so it can protect you. Next slide. You want to go with this one, Barbara?
Okay. Okay, here we go. High yield cardiometabolic framing. Diabetes alters FDG uptake, which affects the PET scan accuracy. Obesity benefits from robotic surgery. They're highly touted for reducing wound complications, primarily because it's a much smaller incision. Vascular disease, increased access, complications. Structural heart, stroke prevention versus bleeding trade-offs.
Do the next one too.
Relative risk versus benefit. This is a conceptual model. So we have ultrasound, cardiac cath, dialysis, and major surgery. And I'm not sure what the
The relative risks show that there's a larger relative risk with major surgery. There's a larger relative risk with dialysis over cardiac cath, and the least risky, of course, of this group is ultrasound. Next slide.
background radiation. Everybody receives natural radiation daily. The average US background is around 3, and I do not know what the unit is in SV per year.
We have a definition later.
Sources include cosmic rays, radon, soil, and food. Medical radiation adds to this lifetime total.
So I mean, just by being even out in the sun, you get cosmic rays, and walking around there's radon in the soil. So we get radiation any way you do. Next slide.
Types of radiation effects. Deterministic effects, such as having a threshold dose of a radiologic procedure, skin burns, and examples of these effects can be skin burns as well as cataracts, rare in diagnostic imaging, but not totally impossible. Stochastic effects, there's no threshold, and cancer risk increases gradually with dose.
Okay. So what is medical radiation? It's ionizing radiation using X-rays, CT scans, and fluoroscopy. Enables diagnostic and life-saving interventions. So basically, technology is good, but it does have risk. It's different from ultrasound and MRI. There's no ionizing radiation in those two procedures. Risk relates to DNA damage. Probably not, was not necessarily certain what that risk is, but it can damage DNA and go forward. Next slide. Okay. So explaining these radiation units. Millisieverts gives you biological effect on the body. It's the best unit for comparing imaging risk. It accounts for tissue sensitivity and exposure types. There are other types called gray. We won't go into that, but sieverts equals 1,000 millisieverts. Next slide. I won't give you a test on this. Okay. You want to do this one, Barbara?
Okay, so this graph is showing relative risk of radiation dose by the type of imaging performed. Going along the bottom with dental x-rays, there's practically no uh, dosage that you need to worry about. Chest x-rays, just a hair more of a radiation dose than dental x-rays. Mammograms are beginning to add on the radiation dose. Head CT gets us up to 2. Chest CT, which is a bigger study, I mean, there's a bigger area that has to be studied, requires the use of more in terms of dosing. So comparing it to the dental x-ray, it's over. Dental x-ray is practically 0, and chest CT is about 7. And then cardiac cath goes all the way up to 12. So this gives you some idea of the radiation dose you are experiencing when you have some very commonly performed procedures.
Okay, next slide. Do this one too, if you would, Barbara.
Okay.
It's similar. You want to do that one?
I don't have it. Oh, this is the new one. Okay, so in this one, we're looking at a comparison of exposures and within the lifetime context. So we are looking at relative dose, uh, looking at chest x-rays, which over a lifetime context is a little bit, but very close to the previous graph in terms of amount. Mammogram also um, very close to what we saw on the previous graph. CT of the chest, the relative dose is much higher than we see for chest x-ray and mammogram. And PET CT, as you can see, is one can expect the highest exposure comparison within the lifetime context.
Okay. Go to the next slide.
Here we're looking at radiation exposure comparison. And background annual is about 2.5 millisieverts. Chest x-ray, very close to 0. Not 0, but very close to 0. Mammogram, about, if there's such a unit, twice as much of almost none as compared to the chest x-ray. But it begins to add up or become greater as we look at the head CT, which is almost 2.5. Chest CT, about 7. Abdominal pelvic CT, almost 10. PET scan, almost 15. And again, PET CT, which is about 22 in comparison.
Next slide. I'll take this one. So FDG that we spoke about before is the active agent for the PET scan. And that's where the radioactive glucose analog is given by IV. It's labeled with fluorine 18, and that's the radioactive thing. It mimics glucose uptake in cells. It gets trapped in metabolically active tissue. Next slide. I'm gonna give you all the graphs, Barbara.
I see. All right, this time we're looking at relative uptake by tissue of the radioactive material in the CT. And if you look at the first bar, which is depicting the relative uptake in the brain, it's a relative value of 90, which is not surprising if you recall what we saw in the previous bar graphs. When they're doing studies of cancer tissue, we see it's almost as high as that uptake in the brain. For the heart, it's a bit lower compared to the brain and cancer at 70. Inflammation is about 60, So that's 60 compared to 90 in the brain. And then in normal tissue, if we were to perform the study, the relative uptake in the normal tissue would be around 20.
Thank you. Let's go to the next slide. So the FTG works in PET imaging. It's injected intravenously. It's taken up by cells like glucose is. It becomes metabolically trapped and it emits positrons. So the PET scanner detects metabolic activity. So the PET shows function, not just structure. That's the important thing. That's why it's so valuable. Let's go to the next slide. So the FDG contributes most in PET scans to the radiation dose. That's why it can be good as well as dangerous. Typical FDG PET scan dose is 14 millisieverts. With a PT-CT scan combination, exposure increases a lot. It's used when diagnostic benefits outweigh the risk, and usually use these in our most severe patients. Next slide. Want to use this, Barbara?
Okay, a visual concept of what Dr. Max had just described. In the brain, you have high physiologic uptake. That means the brain tissue absorbs a lot of the radioactive material. In the heart, there are varying degrees of uptake depending on the glucose and fatty acids used in performing the test. In cancer tissue, there's focal intense uptake, referred to as hotspots. Um, and there are a lot of reasons for that, but probably the most important one to think of it in terms of is that there's more activity, and so there's more by the cells and tissue, and so there you see greater concentration of the contrast material in the study. And then finally, when you're looking at areas of inflammation or infection, if a trained radiologist wouldn't get tripped up on this, but the intensity of the uptake can be quite similar to that seen with a malignancy or cancer examination. FDG uptake reflects glucose metabolism, not anatomy. That means it reflects the cellular activity and not the gross structure.
And in cancer, the cellular activity is usually higher than normal tissue. That's why it's so important. Let's do the next one, Barbara. It's a graph.
PET versus CT versus MRI, what each study shows. So we're going to look at the relative strength conceptually of these three types of studies. With the PET, we see a relative strength in the PET very high. With the CT, very high. And with the MRI, just slightly lower. What I don't know in the graph is what the blue and the red bars represent, Randall.
Okay, so with the PET scan, you get a functional picture that's much deeper than any others. With the CT, it's less accurate. The MRI, you get slightly better. But the PET scan, even though it gives you more activity, it gives you more danger because you're looking at living, metabolizing tissue. Let's go to the next one. Next slide. So FDG versus PET scan, there are common pitfalls and false positives. The false positives that happen, as Barbara said, usually a good radiologist can pick those out. Infections can give you false positive. Inflammation can give you false positive. And also there's post-surgical healing that can give you a false positive. And also there's brown fat, which is different than yellow fat. Activation can also give you a false positive. Also, there are false negatives, such as low-grade tumors, hyperglycemia, uh, poor preparation of the patient, and also there's small lesions that can give you a false negative. Next slide. This graph is not as clear. Let's skip this one. Can you read this one, Barbara?
Okay. So we're looking at the relative contribution of radiation sources, again, as a relative dose share. And this pie graph, which is color coded, is demonstrating background annual, which goes back to maybe the second um, graph that we looked at. The red is the chest x-ray, the green is the mammogram, the purple is the head CT, the turquoise or teal maybe is the chest CT, the orange is the abdominal or pelvic CT, the dark blue is the PET scan, and the maybe brown, we'll call that brown, is the PET CT. So you look at the pie slices and you can compare the different sources to the size of the pie slice. So the PET CT, we would not be surprised to see, has the greatest relative dose share, which we saw on the previous graphs. And the smallest dose share is the mammogram.
That's good for y'all, right?
That's excellent for us since we have to have so many of them.
Yeah, next slide. So the radiation imaging pediatric and versus pregnancy considerations, those are the high risk category. So in young patients, that's Barbara's area, better be concerned. Their kids are higher sensitive to radio sensitivity per dose. They have a longer lifetime, so we want to keep them away from this unless we have to, because cancer can show up in their later lives. We also prefer to use ultrasound and MRI if it's feasible, as opposed to a CAT scan, definitely not a PET scan. And we want to use specific CTs protocols for kids than we do for adults. In pregnancy, there's fetal sensitivity to the highest in the first trimester. And we also, the deterministic effect that are unlikely if it's less than 50. And the diagnostic imaging is usually less than 10. So shielding and dose minimization is very important in pregnancy, and especially in the first trimester, but all the trimesters. So next slide, cardiac catheterization. So cardiac catheterization, the benefits are the life-saving diagnosis that can happen with MI and with shock that happens. There's real-time coronary anatomy that can be seen and cured at that point. The risk, however, of radiation exposure, contact, kidney disease, nephropathy, and vascular injuries that can happen. So we have a clinical balance. The benefits usually overwhelmingly outweigh any acute risk of coronary syndromes. In hemodialysis, next slide, the risk with that, the benefits are that it's life-sustaining therapy in end-stage renal disease, removal of toxins that happen in excess fluid, but there are risks with the inflammation of bioincompatibility that happens, and cardiovascular stress that can also happen during hemodialysis, and also you're exposed to plastic and metals that the body may have a reaction to. So clinical balance is important. Survival benefit is absolute. The technology reduces the harm if you use it correctly. Next slide. I'll take this one, Barbara.
All right. Ultrasound. The benefits are number one, there is no ionizing radiation involved. This is a real-time imaging using sound waves, and it's widely accessible, meaning that many, if not most, facilities have access to this technology as opposed to very limited access to PET scans and little more access to MRIs. The risk is minimal thermal effects, meaning that there are no heat or radiation effects at high intensity, and overuse without indication. I mean, you never want to do stuff that's not indicated, obviously, but there's less risk associated if for whatever reason overuse occurs. And we have a favorable clinical balance, meaning that there's an extremely favorable safety profile because there's much less risk of damage.
Next slide. So we also do something called brain mapping, and there's neurotechnology involved in that. The benefits of brain mapping, it diagnoses epilepsy, tumors, and stroke, and also a way to plan your surgery. The risks are magnetic field interactions and implant interference. If you have something in your brain that is a metal, it shouldn't be there. But the also risks are low with proper screening. Next slide, go into major surgery. So the benefits are it can be curative, protecting or prolonging. It can also restore function, but the risks are there are dangers with anesthesia. I hear that for general anesthesia, the risks are mortality risks at least 1 to 2%. Also, there can be electrocautery injury, and that can be, for example, instead of using a scalpel, it's actually electronic and it burns a cut. Is that the right way to describe that, Barbara? It burns a cut.
Well, yeah,
And also, you get implant material exposure, which can be negative. But the clinical balance is the risks are justified when surgery changes outcomes. Can happen, can be very good for you if you need it. Go to the next one, Barbara, if you take that one.
lifetime radiation risk. Radiation risk is a cumulative over time phenomenal. In other words, you can't just talk about a single procedure. It's the total exposure over the lifetime. Risk is probabilistic, i.e., chance-based, not guaranteed, and measurable population risks seen mainly above 50 to 100 millisieverts. Examples would be if you had approximately 500 chest x-rays, that would equal out the total amount of exposure, radiation exposure would be about 50 millisieverts. If you had 7 to 10 chest CTs, you would have between 50 and 70 millisieverts. So you can have a whole bunch more chest x-rays compared to chest CTs and to get to a total exposure risk of 50 or more.
Take the next one, it's related. Next slide.
Cumulative radiation over time, conceptually. So we're looking at a range from 10 millisieverts to 100, so that we're looking at a relative risk over time. The more you are exposed to, the more you will accumulate exposure to radiation.
Let's go to the next slide.
A LARA principle. A LARA means as low as reasonably achievable. So there are several components to this. You want to minimize the length of time you are exposed to the radiation. It makes a big difference in terms of how close the source of the radiation is to the studied body part. And most importantly, shielding all of the areas that do not need to be exposed to the radiation because they are not part of the study that you're trying to conduct. The overall purpose is to get the most bang for your buck, or to put it in the terms that Dr. Maxey put it, optimize the benefit while minimizing the avoidable risk.
Yeah, I like the word bang for buck. Next slide, I'll take it. The special population we need to be concerned about. Children, they have a higher lifetime sensitivity. Pregnancy, fetal sensitivity, especially first trimester, are very important. Be careful. For the chronic kidney disease, CKD, contrast toxicity and reduced clearance can damage those kidneys and make your actually go into acute kidney injury and even end-stage renal disease. With cardiometabolic disease, there's amplified oxidative stress that can be damaging. So there are tailored protocols for each to reduce the risk. Next slide. Who is the most vulnerable? CKD patients, diabetics, elderly, people with cardiometabolic disease, and these populations do all require tailored protocol and risk reduction. Barbara, take the next one.
So how does one go about reducing risk? Well, you try to use the lowest emitting effective dose technology. What that means is if you can take care of it with a technology that exposes you to less radiation, that would be where you would go. You might be able to get the information that you need using a different technology, but you are using or will create more exposure to radiation using that other method. So you want to use the lowest effective dose possible. You want to use as little contrast material as possible. You want to make sure that the substances that are used are biocompatible. In other words, you don't want to use things that are going to create problems of their own because you use them. And you want to, it's very important that there is, before you have the procedure and after the procedure, adequate hydration. And the patient needs to understand what the tests are trying to do and engage in an informed conversation with the physician so that there is shared decision making by the patient and their physician.
Next slide. So there's some key takeaways. No fixed number of safe X-rays or CT scans. Risk depends on the dose, your age, and the clinical necessity of the test. Benefits usually outweigh risk when imaging is justified. ALARA, or ALARA, protects patients and healthcare workers as well. It's important that workers are at risk as well. Other key takeaways are technology itself is rarely the primary danger. Benefits usually vastly reduce the risk, but it's all cumulative and it's patient specific. Transparency improves trust and outcomes. Thank you very much. Any questions on this? We didn't try to take it to medical school, but I think we wanted to orient you to some of these things that people have been afraid of, but we need to know that you know what you're looking for. And going to a PET scan, something better be pretty serious. You can't go there for a cut finger. You go there for something that's life-threatening because there's a lot of radiation there. Any question in the chat, Barbara?
Not yet. I wanted to ask you to discuss very briefly some tests that we alluded to at the beginning of the talk, the cardiovascular testing. Could you talk about that?
Yes. So cardiovascular testing, we know that there's cardiac catheterization. In cardiac catheterization, where we look at the coronary arteries, and usually if somebody's had an event, we can determine their calcium score. We can do cardiac CT. We can look at the patency of the blood vessels, especially the left anterior main vessel, and determine if it's clogged or how much it's clogged. And in some cases, we can percutaneously put a balloon in there and open up and cure that problem in some cases. We can also, in the process, affect valves. And there are techniques now that don't require open heart surgery, but you can do closed heart surgery by percutaneously inserting a new valve or repair a current valve there. If that's some of the things you speak about, Barbara.
Yeah, and then because these procedures are done so often now, and sometimes in very urgent situations, could you go over the usual and customary studies that are done on a stroke protocol?
On stroke protocol, and I've had that question put to me before, that when you go in, they'll suggest that they use a clot buster. There are two types of strokes. There's a hemorrhagic stroke and there's an obstructive thrombotic stroke. And they'll want to use a clot buster if it's a thrombotic stroke. And the thing is that it can make it worse or it can make it better. And they'll give you a set of percentages of which one is which. And they told me that a stroke would get potentially worse was 30%, and to get better was something like 15%. I said, no, I don't want it. So you want to hear those percentages before you do it. It may not be worth doing, but they do it so often that it can be life-saving and also can save you from disability in the stroke. The same with the percutaneous cures of coronary artery disease. You want to know what your percentages are and give that cardiologist your permission before you go into it so he can do what he needs to do, because there's anesthesia risks, there's cardiac risks and everything, but know what you're doing and have your family there with you to help you make those decisions beforehand.
So we do have a question in the chat. What is the risk benefit of annual brain MRIs with and without contrast for multiple sclerosis? Very specific question.
Whoa, that's a heavy one. Well, I think the risk of an MRI, the MRI radiation is minimal. The risk with the MRI is with and without contrast. And using the contrast would be primarily risky if you have CKD, a chronic kidney disease. That would be a rule out. If you have kidney disease, you don't want to use contrast. But so with multiple sclerosis, I think the issue is kidneys, not so much the multiple sclerosis. But if you have multiple sclerosis in conjunction with kidney disease, that's where the contrast would be at risk, if that answers the question. You want to unmute them, Simon, if they can answer it verbally, if they want any other part of that answer? Whose question was that?
That was Dr. Germani.
Can we unmute them?
They
Okay,
are
can you hear me?
unmuted.
Yes.
Yes.
Okay, good, good, good. This is Dr. Germany. Excuse me. I was asking, especially because of the if anyone, has any kidney issues, that are not major, but things like I don't know, the serial MRI scans to track any new lesions and things like that in multiple sclerosis. Those are things that to me would leave. I've had a patient that would leave me in the absence of overt, issues from any multiple sclerosis. Doing them serially it seems like it would be a concern, and especially as you said, if contrast is used. But if they're saying that the efficacy of the MRI in terms of any new lesions is improved by using contrast, then it's kind of hard to tease out to me.
Yeah,
So
the primary thing that contrast is danger to is if you have some form of kidney dysfunction. It's not so much that it would be looking for new, it wouldn't hurt the new lesions of the brain or tissue, but it mainly affects the kidneys in a negative way.
so the
So
MRI, if the MRI were done without contrast, is I
there's
don't know.
minimal damage, minimal.
Yes.
If it,
So the efficacy of the MRI without contrast in terms of looking for any new lesions. So bottom line is, would contrast be needed when you're doing the MRI and looking for any new lesions, active lesions?
you'd want to use contrast if you can. Yes.
Okay. Okay. Thank you.
Okay. Any other
Okay.
questions?
Not at the moment. We don't have any more.
Well, we're getting close to the top of the hour. So let's have final comments, Barbara.
I'm thinking about when I was a child and maybe even into early teen years.
Couple of years.
There, there was when we had color TVs introduced, there was a lot of talk about radiation from the color TVs. And then as microwaves came along, there was a concern about what we were going to get from the microwave. And let's not forget all of the discussion that the cell phones created around brain cancer. The point I'm trying to make is as new technologies come along, and they will continue to come along, it is important to have a conversation about risk, relative risk, so that you can make an informed decision as to what you will or will not expose you and your loved ones to. And I hope that this conversation today, it wasn't very deep, but it does give you enough information to know that you need to ask questions so that you can make informed decisions.
Thank you very much. And for my final comment, I hope you go back and look at this presentation, look at some of the things that we spoke about. It's very important to be able to ask questions, but know the general lay of the land. Medical technology is important, but it's not something you can always see up front. You have to ask questions, be reasonably knowledgeable, and take family members with you when it's a serious intent to make sure that they're being upfront and transparent with you. Have a great day. Thank you, Dr. Neighbors Stevens. Thank you, Simon. Have a great Sunday. Who's going to win the football game today? I don't know. Have a great day, everybody. Thank you, Simon.
Bye-bye.